Hello, and thank you for joining today's NCCN patient webinar, Know What Your Doctors Know, Basal Cell Skin Cancer. My name is Tanya Fisher, and I am the moderator for today's webinar. NCCN stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 32 leading cancer centers across the United States, devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines, as well as patient webinars. These are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website. High-quality printed copies of the book can be purchased through Amazon. The Know What Your Doctors Know webinars complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers have an opportunity to ask questions at the end of the presentation. This brings us to the presenters for today's webinar. I'm very pleased to introduce Dr. Sue Park. Dr. Park is a medical oncologist and assistant professor of medicine at University of California, San Diego Health. Following Dr. Park, we will hear from Michelle Offner, who is an oncology nurse practitioner at Cedars-Sinai, the Angeles Clinic and Research Institute. Our third presenter today is Samantha Guild, patient advocate from the Skin Cancer Education and Research Foundation. Now I will turn it over to Dr. Park.
Hello, everyone. I hope everyone can hear me okay, and thank you all for joining us today. I would like to thank NCCN for the opportunity to talk about basal cell carcinoma, and I am thrilled to be joined by two wonderful colleagues who you will hear from later in this webinar as well. And today, I will be reviewing basal cell carcinoma from the beginning to the end. And I think this is really important because when we understand what causes basal cell carcinoma and the factors that increase your risk of getting it, we can help you prevent it or detect it at an early stage when it is the most curable and the easiest to treat. And that goes for all skin cancers. So what is basal cell carcinoma? Basal cell carcinoma is a non-melanoma skin cancer. Non-melanoma skin cancer refers to all the types of cancer that occur in the skin that are not melanoma. And basal cell carcinoma and squamous cell carcinoma are the two main types of non-melanoma skin cancer. Basal cell carcinoma starts in the basal cell skin layer. These cells are in the lower part of the epidermis, which is the top layer of our skin. And the basal cell layer here is the dark purple layer that you see. Basal cell carcinoma develops when ultraviolet or UV radiation causes DNA damage of these basal cells. Here you can also see melanocytes in the basal cell layer, which are the skin cells that produce melanin, which give color to our skin, eyes, and hair, and that is where melanoma begins. Squamous cell carcinoma begins in the flat squamous cells in the upper part of the epidermis, and here you can see that in the light purple color. So basal cell carcinoma is the most common form of skin cancer and accounts for about 80% of all skin cancers, and it is also the most common type of cancer in the world. Since basal cell carcinoma is a ultraviolet light-driven cancer, it is much more common in white populations whose skin is more sensitive to sunlight. But I do want to stress that skin cancer is colorblind. Anyone can get skin cancer, no matter the color of your skin. And in fact, I don't know if many people know, Bob Marley died of melanoma in 1981 when he was only 36 years old. The incidence of basal cell carcinoma is increasing, and this is probably due to a combination of factors such as improved skin cancer detection, more sun exposure, and people living longer. The incidence is also higher in men, and this is thought to be due to more sun exposure. Basal cell carcinoma is also more common in older people, and this is probably due to accumulation of sun exposure over time. But these cancers are also becoming more common in younger people, and this may also be related to more sun exposure as well. Exposure to ultraviolet or UV radiation from natural or artificial sunlight is the most important risk factor for basal cell carcinoma. And so where you live also affects your risk. The closer you are to the equator where the sun rays are strongest, the higher the incidence of basal cell carcinoma. And this is also why people who have fair or light-colored skin are at higher risk for developing basal cell carcinoma. Other established risk factors include older age, male gender, having had a previous skin cancer, having a weakened immune system from certain diseases or certain medications, and certain inherited conditions. Our understanding of the molecular drivers in basal cell carcinoma came about in a group of patients with Gorlin syndrome, and this syndrome is also known as nevoid basal cell carcinoma syndrome. Here you see a young patient with Gorlin syndrome who has hundreds of basal cell carcinomas on his upper arms and neck. And I mention this since this will help us understand one of the treatment options for advanced basal cell carcinoma. Gorlin syndrome is named after Dr. Robert Gorlin, who was actually not a medical doctor, but he was a dentist who had specialized training in oral pathology. And he fortuitously discovered this syndrome in 1958 after seeing a female dental patient with numerous jaw cysts who had many basal cell carcinomas over her body. And this eventually led to the discovery of similar patients who had mutations in the patched or smoothened genes, which are part of the Hedgehog signaling pathway and are critical to basal cell carcinoma development. The other important gene in basal cell carcinoma development is the TP53 gene, and this gene plays an important role in preventing mutations by repairing DNA and getting rid of cells when the DNA damage cannot be fixed. And this is how TP53 got its nickname as the guardian of the genome. And these mutations, particularly mutations in the patched gene and the TP53 gene, are most likely caused by UV radiation damage. Here you can see a schematic of the Hedgehog signaling pathway. So this pathway is really important for embryonic development, but in adults, this pathway is inactive. The patched and smoothened genes code for a cell membrane receptor complex that you can see here in blue and green. Activation of this pathway is normally blocked by the patched receptor, which holds smoothened in an inactive state. But mutations in the patched receptor release the hold that patched normally has on smoothened and allows smoothened to activate the Hedgehog pathway and cause basal cell carcinoma. You can also get mutations in the smoothened receptor, which can result in constant activation of the Hedgehog pathway. So here is a molecular report from a patient of mine with basal cell carcinoma, and you can see here that this patient has mutations in the patched gene, the smoothened gene, and the TP53 gene, which are all responsible for the development of basal cell carcinoma as we just reviewed. So now let's talk about what basal cell carcinoma looks like and what that means. So basal cell carcinoma typically grows slowly, and it can show up on the skin in many different forms. They can appear as shiny bumps, scaly patches, open sores, and even scar-like lesions. And their appearance can overlap with other skin disorders like psoriasis or eczema. And basal cell carcinomas are often fragile and bleed easily after minor injury. They are also characterized by something called a continuous healing pattern, meaning that they sometimes will bleed, scab, and heal over, only to bleed and become irritated again. The main warning sign is a spot that does not go away on its own. So if you notice any spot on your skin that is growing, bleeding, or changing in any way, please see your doctor. Basal cell carcinomas usually develop on areas exposed to the sun, especially the face, scalp, ears, neck, chest, shoulders, and back. And as we reviewed, they can have varying appearances, and these are often divided into three main groups: nodular, superficial, and morphiiform. Nodular basal cell carcinomas are the most common and present as a shiny pink or flesh-colored papule that can sometimes be ulcerated. Superficial basal cell carcinomas typically present as a flat, slightly scaly patch that can sometimes have raised edges. And these are more common in men and tend to be asymptomatic. Morphiiform basal cell carcinomas resemble white, waxy, scar-like lesions, and they don't have well-defined borders, and these tend to exhibit aggressive biological behavior. So while dermatologists are often able to make the diagnosis during their exam, a skin biopsy is needed to confirm the diagnosis. And a skin biopsy will also provide information on the basal cell carcinoma subtype, which is important for prognostication since we know some subtypes are more aggressive than others. And since basal cell carcinoma rarely spreads to other parts of the body, imaging tests are usually not necessary unless your doctor thinks you might be at risk for the cancer to spread outside the skin. So for example, if the basal cell carcinoma is very large, or if there are concerning findings on your physical exam, or if there are high-risk features when your skin biopsy is viewed under the microscope by the pathologist, then imaging may help us determine if the basal cell carcinoma has spread. Although most cancers are assigned stages to determine how far a cancer has spread, basal cell carcinoma is rarely staged. And again, this is because it is rare for basal cell carcinoma to spread to other parts of the body. But for those times when we do stage basal cell carcinoma, staging is based on how deeply into the skin it has grown, such as stage 0, for basal cell carcinoma that is confined only to the top layer of skin, the epidermis, size of the tumor for stages 1 and 2, and whether the cancer has spread to nearby areas or to distant sites for stages 3 and 4. For basal cell carcinoma, we can assess recurrence risk based on a number of features that can help us categorize basal cell carcinoma with a low likelihood for recurrence after treatment and those that have a high likelihood for recurrence after treatment. This helps us select the appropriate treatment. The characteristics seen here are features associated with a low risk of recurrence. So here we have a size of less than 2 centimeters for a basal cell carcinoma on the trunk or extremities, well-defined borders, a primary lesion and not a recurrent one, with no prior radiation or coexisting immunosuppression. The nodular and superficial subtypes that we reviewed are considered low risk, along with the lack of perineural involvement, which is when the cancer invades the space surrounding the nerves. Features associated with a high likelihood for recurrence after treatment are shown here. These include a basal cell carcinoma that is 2 centimeters or greater on the trunk or extremities, and a basal cell carcinoma of any size on the face, neck, scalp, hands, feet, and genitalia. Lesions with poorly defined borders are considered high risk, as are recurrent lesions, and those that arise in sites of prior radiation and those associated with an immunocompromised status. Several subtypes are also considered high risk, including the morphiiform subtype that we reviewed, along with the presence of perineural involvement. So now that we have reviewed how basal cell carcinoma develops and its risk factors, what it looks like, and the features associated with recurrence, how do we treat it? So surgery is typically the first-line treatment for local basal cell carcinoma, whether it is low risk or high risk, but the technique used is different. For low-risk basal cell carcinoma, standard surgical excision with margins of 4 to 5 millimeters is the recommendation. This technique is what most of us commonly think of when we think about surgery. The surgical specimen is cut into vertical sections like a bread loaf for pathologic review under the microscope, to make sure that the margins or the edges are free of tumor. So here you can see that a portion of the tumor was missed, but you would not have been able to tell when looking at the slides a week later after the surgery has already been performed, which is why there is this 4 to 5 millimeter margin recommendation to try and catch all the tumor at the first time. With surgical excision, the recurrence rate is typically less than 5% or so. There is also another procedure called curettage and electrodesiccation, where a dermatologist will scrape off the cancer cells from your skin and then burn the area. But this procedure is often reserved for older patients who have superficial low-risk basal cell carcinomas on areas like the chest and back, areas where you wouldn't mind having a scar. But although curettage and electrodesiccation is a fast procedure and one that does not require stitches, there is no true margin assessment, and so there is the risk of incomplete tumor removal, but this remains an alternative option for select patients with low-risk superficial basal cell carcinoma. For high-risk basal cell carcinoma, a special type of surgery known as Mohs micrographic surgery, or just Mohs for short, is the first-line recommendation. The Mohs surgeon will first start by cutting out the skin cancer that can be seen, and then they will take a thin layer of surrounding skin tissue and remove that. The surgeon will then look at this thin layer of skin tissue under the microscope in real time during the surgery. And if the surgeon finds any cancer cells in the skin layer, then the surgeon will go back and remove another thin layer of skin in the area where the cancer cells were found on the skin layer that was just examined. So this process of removing another thin layer of skin and examining it under the microscope continues until the surgeon can no longer see any more cancer cells. And with this technique, you would have caught that portion of tumor that was missed and been able to go back and take another layer of skin until it was clear. So sequentially removing thin layers of skin tissue around the skin cancer, both at the periphery and at the base, the deep margin, makes it possible for the surgeon to assess 100% of the margins, and this is why Mohs surgery is preferred for high-risk basal cell carcinoma. For patients who may not be surgical candidates for whatever reason, we can consider primary radiation to the basal cell carcinoma and expect fairly good outcomes, but it is still not as good as surgery, because with radiation, you are not able to assess the tumor margins either. Other patients end up having positive margins after surgery, and if you cannot do additional surgery to remove that positive margin, then we can also consider post-operative radiation to treat the residual tumor. And in some cases where the margins are actually negative after surgery, but the tumor has certain high-risk features, like extensive perineural involvement, we can discuss the risks and benefits of radiation to further reduce the recurrence risk. So for patients with advanced basal cell carcinoma, and we often define this when the disease cannot be adequately managed with surgery or radiation, a multidisciplinary tumor board discussion is highly recommended, because with clinical trials, new therapies coming out on the horizon, defined areas of clinical expertise, and different ways to sequence therapy nowadays, it is helpful to have different specialists work together to deliver complex medical care. And if there is a clinical trial that may be available to you, whether it is a surgical clinical trial, a radiation clinical trial, a dermatology clinical trial, or an oncology clinical trial, we always encourage patients to find out more information about clinical trials in general. Clinical trials represent the forefront of medical research and help us find ways to help patients live longer, improve their quality of life, and manage or cure their disease. And we must remember that all standard treatments that we use today were once part of a clinical trial. So let's go back to the Hedgehog signaling pathway, which we know is a key driver in basal cell carcinoma development. So up to 90 to 95% of patients with basal cell carcinoma will have mutations in either the patched, gene or the smoothened gene, which then leads to activation of the Hedgehog signaling pathway and uncontrolled cell growth. So vismodegib and sunitigib are the two oral drugs known as Hedgehog inhibitors, and they bind and inhibit the activity of the smoothened gene, which then blocks activation of the Hedgehog pathway. And these drugs are for patients with locally advanced or metastatic basal cell carcinoma that can no longer be adequately managed with surgery or radiation. Vismodegib was studied in the ARAVANCE trial and has FDA approval for basal cell carcinoma that is locally advanced or metastatic, while sunitigib was studied in the BOLT trial and has FDA approval for basal cell carcinoma in the locally advanced setting. And again, these two drugs are available to us today as a result of clinical trials. Both the ARAVANCE and BOLT trials were phase 2 studies. In the final 42-month analysis for sunitigib in locally advanced disease, the overall response rate by central review was 56%, with a median duration of response of 26 months. The vismodegib numbers that you see here were from the 21-month analysis, since this was the only set of data that was centrally reviewed. However, the final update at 39 months for vismodegib in locally advanced disease, which is not shown here, demonstrated an overall response rate of 60% by investigator review, so not central review, with a median duration of response of 26 months. So very similar responses with good durability between the two Hedgehog inhibitors for locally advanced disease. And for metastatic basal cell carcinoma, the overall response rate to vismodegib was 48%, with a median duration of response of nearly 15 months. So that's pretty good as well. So treatment with Hedgehog inhibitors is often limited by toxicity, some of which may be intolerable. And there was a fairly high patient discontinuation percentage of around 50% in both the ARAVANCE and BOLT trials. For sunitigib, one mitigation strategy is to dose the drug every other day, which is actually included in the drug label, but I will let you hear more about drug toxicities from Michelle. So for those patients who are not eligible for additional surgery or radiation and cannot tolerate or have progressed on a Hedgehog inhibitor, we now have another drug that was approved last year in February 2021. So this drug is called Cemiplimab, and this drug is a programmed cell death 1 inhibitor, also commonly known as a PD-1 inhibitor. And Cemiplimab is not chemotherapy, but rather an immunotherapy agent that is given intravenously. So here you can see the cancer cell in gray and the cancer-killing T cell in blue. T cells are very important cells of our immune system. The interaction of the PD-L1 protein on the gray cancer cell with the PD-1 protein on the blue cancer-killing T cell results in a state of T cell inactivation. But Cemiplimab can bind to the PD-1 protein on the blue cancer-killing T cell to block the interaction with the PD-L1 protein on the gray cancer cell to help restore cancer-killing T cell activity, thus activating these T cells. So Cemiplimab was approved by the FDA based on study 1620. This study included 112 patients with locally advanced, unresectable, or metastatic basal cell carcinoma who had disease progression, intolerance, or no measurable response on a Hedgehog inhibitor. Certain patients were not eligible for this study, including those with autoimmune disease on immunosuppressive therapy and solid organ transplant recipients, among other groups that were also not eligible, as you can see here. And patients in this study received Cemiplimab for almost 2 years. For patients with locally advanced disease, the objective response rate was 31%, with 6% of those being complete responses, meaning that all the target lesions had disappeared, and 25% were partial responses. 79% of patients continue to have responding disease lasting 6 months or longer. the objective response rate, it was a little bit lower at 21% for patients with metastatic disease, and all these responses were partial responses, none were complete. But still, all the responses in metastatic disease were ongoing, lasting 6 months or longer. And I cannot emphasize this enough, but this new treatment option, which was approved just last year, is now available to us because of all the patients who graciously participated in this clinical trial to help us move the needle forward in cancer care. There is a unique but broad group of side effects associated with immunotherapy agents like Cemiplimab called immune-related adverse events. These side effects can affect many different organ systems, as you can see here. Since immunotherapy drugs help restore the cancer-killing T cell activity, sometimes these T cells can also attack normal tissues in addition to the cancer cells and cause an autoimmune-like response against many organs, which can manifest as like a rash, liver injury, thyroid dysfunction, just to name a few. And these immune-related toxicities can develop at any time during treatment, even months after stopping treatment, but most are manageable. They can also be fatal if not caught early and managed appropriately, so it is really important to follow very closely with your doctor anytime you are on cancer therapy. And Michelle will be reviewing these toxicities with you as well. And lastly, a slide on prevention. Our best defense against basal cell carcinoma is prevention, primarily through sun protection and regular dermatology visits for skin checks. For patients who are not immunocompromised and have recurrent non-melanoma skin cancers, including basal cell carcinoma, taking oral nicotinamide twice a day may reduce your rate of developing new non-melanoma skin cancers. And this is something you can discuss with your dermatologist. And spotskincancer.org is a great online resource if you would like to learn more about skin cancer prevention. And I think Samantha will also talk about other great ways to get involved in the non-melanoma skin cancer world. And now I will turn it over to Michelle. Thank you.
Thank you, Dr. Park, for that fantastic presentation. My name is Michelle Offner. I'm a nurse practitioner at the Angeles Clinic and Research Institute in Los Angeles, California. I work with the cutaneous malignancies clinic. So we see everything from melanoma, squamous cell carcinoma, basal cell, as well as the rare Merkel cell carcinoma. So today we're going to talk about some of the common side effects of the therapies that Dr. Park just reviewed. For the Hedgehog pathway inhibitors, one of the more common side effects is hair loss, also known as alopecia. This is most commonly transient but can be permanent. Muscle spasms and or joint pain, loss of impaired or altered taste, weight loss, nausea and vomiting, which of course contributes to weight loss as well as fatigue and weakness, and laboratory abnormalities such as low potassium, low sodium, alterations in magnesium levels. Another side effect for those who are of childbearing years is loss of menstrual period, as well as rashes. As far as immunotherapy, Libtayo or Cemiplimab, the most common side effect is itching and rash. Can cause inflammation in the colon, which presents itself as diarrhea. It can cause inflammation in the liver, which can present itself as nausea and or vomiting. Inflammation in the joints or in the muscle tissue, which can present as joint pains or muscle pains, generalized weakness, and it can also cause fatigue. Now, the most important management strategy for any type of therapy is to have an open line of communication with your provider. Knowing your baseline, so knowing what your body's normal functions are, is very important. And then any changes or alterations in that should be a discussion with your provider so that we can try to minimize these toxicities as much as possible. So for managing hair loss or alopecia, it's important to avoid any harsh products or chemicals, such as dyes. Avoid anything that can pull at the hair follicles. So for women using straighteners or curling irons, excessive hair brushing or consistently wearing hats. For management of muscle cramps, just sort of getting those muscles moving, loosening them up. Exercise, massage, TENS therapy can be helpful. Also, optimization of electrolyte balance. Sometimes these muscle cramps come from electrolyte alterations, so making sure that our magnesium and calcium levels are normal, making sure we're getting enough water is important. Loss of impaired or altered taste. So, sometimes in these therapies you really don't feel like eating because the food just doesn't taste good, especially if you have something accompanying it like nausea or vomiting that, it's even less likely that you may want to eat. So just trying to eat small or frequent meals, eating things that you like. We don't have any, foods that we say that you need to avoid while on these therapies. So whatever you can eat is great. If you need to use seasoning or adjusting your salt or sugar levels on the foods, it may be helpful. Avoiding things like, super hot foods, things at room temperature may be more tolerable. Avoiding metal dishware. Sometimes that can cause more of a metallic taste. And maintaining a good oral hygiene can be helpful. Weight loss, this is typically attributed to the alterations in taste as well as nausea or vomiting, not allowing you to eat as, you may normally. So trying to get things in that are high protein and high calorie. If you're not familiar with what those types of foods are, your provider can always refer you to a nutritionist who may be able to help suggest some, appropriate supplementation. For nausea or vomiting, for something mild, you can use things such as ginger, avoiding really fatty foods or things that have a, very pungent smell to them. For the symptoms that are more moderate, you can discuss with your provider prescription antiemetics, so things such as Zofran or Compazine, which may be helpful to take prior to eating. We usually recommend that you take these about 30 minutes prior to a meal. And to combat fatigue and weakness, I think this is multifactorial. This can come from the weight loss. It can also come from, not wanting to really move because you're not feeling well. So just trying to sort of get in some regular exercise, doing what you can, getting good sleep, doing things that you enjoy is really important while on therapy. So management strategies for immunotherapy, these are a little bit different. Anything that can be inflamed can become inflamed while on immunotherapy. So there's a very long list of what can happen, but we'll just go over what's the most common, which is in our practice what we see, itching and rash. So things that you can do on your own is be prepared, have topical steroids such as hydrocortisone at home. So if these rashes do come up or itching presents itself, you can sort of get ahead of it. Oral antihistamines, I like to recommend things like Claritin or Allegra during the day, or non-drowsy Benadryl. And then Benadryl if you need to in addition to that. The reason I recommend using the Claritins or Allegras first is because Benadryl can tend to be to make people drowsy. Also, keeping your skin hydrated, avoiding like really hot showers or avoiding hot tubs can just help to calm down some of that irritation. Diarrhea is one of the more common side effects. Typically presents itself as low grade. However, this can be very dangerous. If we have inflammation in the colon that is not treated properly, it can cause lots of fluid loss, electrolyte imbalances, and it can really be dangerous if left unaddressed. So the first thing that I recommend our patients do is just to notify your provider so that we're aware and we can kind of keep a close eye on you. You can use Imodium, which is over the counter, so that's a good thing to sort of keep at home if you know you're going to be going on to one of those regimens, so that, if this does come up, you're not running out in the, the middle of the night when you're not feeling well. I typically recommend 2 tabs with each loose bowel movement, as well as avoiding things like spicy foods, caffeine, and dairy, which can be irritating to the bowel. Combating fatigue is one of the more difficult side effects to manage because this is also multifactorial. One of the most important things we can do is check your blood and make sure your hormone levels are all within balance. These therapies affect the organs which produce your body's hormones. So sometimes these imbalances are related to something that we need to correct with medication. Also things like aerobic exercise, good sleep hygiene, relaxation when possible. Those are all things that can sort of help to combat fatigue. And joint or muscle pains, these are also important that we notify, our provider if this does occur. Sometimes we can get some severe inflammation in the muscle tissues, which we may need to manage with, treatment holds or delays. To combat it on your own, you can use anti-inflammatories that are over-the-counter, such as ibuprofen or Aleve. I think those work better than something like Tylenol, but you can also use Tylenol if that's your preference. Again, this is a very short list of the many, many side effects that can occur from these therapies. The most important thing is that if anything comes up that is different from your normal, that you have an open line of conversation with your provider, and we can sort of help to identify and then alleviate these side effects so that we can continue on with therapy, or if we need to make the determination to take breaks as are appropriate. Thank you very much. I'm going to now pass forward to my colleague Samantha Guild to talk a little bit more about patient advocacy.
Hi. First, let me say thank you to the previous speakers. I'm really honored to be being on this panel with you today. My name is Samantha Guild. I am the president of the Skin Cancer Education and Research Foundation, SCRF for short. So I became involved in skin cancer advocacy after my sister Charlie, at the age of 26, passed away from melanoma, and my family wanted to do more to give back to the skin cancer community. So we first launched the Aim at Melanoma website, and more recently we launched SCRF to help those specifically in the BCC and SCC community. And so I'm really excited here today to discuss with you the role of patient advocacy. I first want to tell you a little bit about SCRF and to let you know some of the resources that we have available for you. So we have webinars, educational materials, survivor stories, photos. We discuss the treatment options as well as side effects and how to live with those, how to help manage those. And again, this website was specifically created for the BCC and the SCC community because something like this did not previously exist. So what is advocacy? So you're likely here because you're a patient or you're a loved one with BCC. And our first two guests have given us a tremendous amount of helpful information about the disease, its treatment, side effects, and more. But I want to speak to you not about the disease itself, but actually a related subject. You may be interested in preventing the disease in your family and the general public, those you love within your community, as well as supporting others who have BCC. And so you may be interested in helping to make treatment for BCC better for patients, or interested in helping to find a cure. All of those things are related to what we call advocacy. And if you're interested in advocacy, I wanted to share with you a few ways on how you can get involved. So what are ways to get involved with advocacy? One way to get involved is through skin cancer related legislation. And I'm going to give you an example. We're all familiar with those indoor tanning beds and how many people develop skin cancer as a result of that. Well, your state may be one of those states that has not yet passed a ban on indoor tanning for minors. And so you can help convince legislators to actually introduce a bill that would ban those devices for those under 18. Maybe you're in a state that's debating a bill. You can write a letter of support or speak in support of it. You can write an op-ed piece, maybe, or you can help find others who want to get involved. All of this goes a long way in getting these bills passed into law. And we've fortunately been able to accomplish that in many states, but there are still some of those that have not yet addressed it. Sharing your story is also another way to get involved. So for example, on our site, there's a place where people can share their BCC story. You can draw strength and information about reading about your fellow survivors. Just by telling your story, you can help others. Another way to get involved is through patient panels. So we're often asked by providers, industry, and government agencies to introduce them to patients who might want to speak about their experiences. Patient experiences or caregiver experiences help them understand where their shortfalls, needs, and the weaknesses exist. Again, if you're interested in this potential opportunity, I want to encourage you to reach out to us. Similarly, there is a need for patient voices on clinical trials. And we heard earlier about how, clinical trials can lead to treatment options. Patients are incredibly helpful to researchers as they design these trials to make sure that they fit the patient and not just the goal of the research. Again, if this interests you, I encourage you to reach out and hopefully we can get you connected to somebody soon. Finally, and I know this is a little bit self-serving, but I want to encourage you to share the SCRP website with anyone you know who's interested in BCC. It talks about prevention, early detection, treatment options against side effect management. As we all know, knowledge is power, or why else would we be here? So again, I would ask you to share the site. So again, the site is skincancerinfo.org. Again, I want to thank everybody for being here and learning more about the disease. And please, feel to reach out if you have any questions. Thanks.
Okay, so I see that we do have a few questions. This first question is, what is basosquamous cancer?
That's a great question. Thank you. So basosquamous cancer is actually a very rare type of non-melanoma skin cancer, and it actually has features of both basal cell carcinoma and squamous cell carcinoma. And there's a lot of research behind this type of rare variant, but the current thinking is that perhaps it's a basal cell carcinoma that got irritated. And so when basal cell carcinoma sometimes gets irritated, it can transform some of the cells into a squamous cell carcinoma. And that's why you can sometimes have two different types in one cancer, which is why they call it basosquamous cancer. And so we would lump this as more of a high-risk histology or a high-risk basal cell carcinoma because it has more of a tendency to come back because it's more aggressive. And so for those cancers, we typically do recommend Mohs surgery to make sure all the margins are clear if the basosquamous skin cancer is local.
Great, thank you. And so here's a question about cryosurgery. So what role does cryosurgery play?
Yeah, so cryosurgery is more commonly used for actinic keratoses, not really for basal cell carcinoma. It can in select situations, just like when I spoke about keratosis and electrodesiccation, particularly for patients who have low risk superficial basal cell carcinomas that, and they cannot get surgery. It has a higher chance of the cancer coming back, mainly because you're just freezing the lesion compared to keratosis and electrodesiccation, where before you burn the area, you actually are, removing and scraping the skin cancer cells off. So cryosurgery is an option, but a less preferred option and one that is not commonly utilized for basal cell cancer unless we feel like it's best for the patient. So that's a discussion between you and the dermatologist.
Okay, great. It looks like there are a couple of questions about nicotinamide B3, right? So what total daily dosage is recommended? And then it says take half twice a day, question mark?
Yeah, so in the trial, it was published in New England Journal of Medicine in 2015. The dose that they did use was 500 milligrams twice a day, and they took it for 1 year.
Okay. This person is recovering from Mohs surgery and had treatment by a reputable provider and is curious about the role of vitamin B3 since it wasn't discussed as a prevention strategy. I'm assuming with their provider or by their provider.
Yeah, I think a lot of people don't know much about oral nicotinamide, even though it was published in a pretty big medical journal. I feel like mainly dermatologists and medical doctors that interface a lot with patients with skin cancer know most about it. So it's just a vitamin. It doesn't really have that many side effects at all. Most of us take vitamins every day. And so I think it is worth a discussion if you are the type of patient that gets a lot of these non-melanoma skin cancers. You can also talk about it with your primary care doctor to see if it'd be an option. It's something that you can also purchase over the counter.
So how would you phrase that question with your provider, to your provider?
So I think it would be very appropriate to say, look, I heard about this vitamin B3 that can potentially help me, reduce the rate at which I get these skin cancers. Is this something that we can discuss and maybe, I can start taking? And I think that opens the conversation.
Okay, great. And what should be included in a yearly skin exam?
So if you are fair-skinned or you have a history of skin cancer personally, or you have a very strong family history of skin cancer, I think it is always worth going to the dermatologist once for a full total body skin check. And then if they find something on you, they can then dictate how often that they feel you need to be seen by them for total body skin checks. But I think it also helps for patients to just check their skin on their own at home. And it really helps if you have a partner that can also check with you, because it's really hard for us to check certain areas of our body. And so we typically recommend doing skin checks once a month if you feel like you are at an increased risk of getting skin cancers.
Thank you. So Samantha, did you want to add something to that?
No, I was actually going to mention to Kayla's one. So we strongly, sorry, since I was going to tell you I could help her out a bit. So we strongly encourage people to get second opinions. There's nothing wrong with that. I can't speak to whether your doctor is correct or incorrect as to their opinion. But in any situation, we think getting a second opinion is always a great idea. For a couple of different reasons. One, if it gives you the opportunity to get as much information as possible to decide what your next steps are. And I was going to mention that on our website, we have a place where you can look for an expert in your area. So if you're welcome to reach out to me and I can help you find that on our website.
Okay, thank you. The next question is, what are the recommendations for patients who are positive for Lynch syndrome?
Oh, that's a great question. So Lynch syndrome, it's the most common cause of hereditary colon cancer, and it's also associated with other extracolonic cancers, including skin cancer. Although skin cancer is probably lower on the list of the other cancers that patients with Lynch syndrome can get. And so for patients with Lynch syndrome, the typical recommendation is to have at least one visit with a dermatologist for a total body skin check. And then after that, if they don't find anything, then it's appropriate to see the dermatologist every 1 to 2 years.
Okay, great. Does liquid nitrogen ever have a place in early treatment?
Yeah, so this is similar to the question about cryosurgery, which typically uses liquid nitrogen. So as I said before, I think liquid nitrogen or cryosurgery is typically not really used for basal cell carcinoma, but it can be considered in very select patients who are not surgical candidates and also who may have problems with healing because curettage and electrodesiccation, because you are scraping the skin cancer cells from the skin and then burning the area, you do have a small wound that does heal over time. And so some patients, if you have peripheral vascular disease or, very fragile skin that, tends to heal very poorly anytime you, remove or cut into it, maybe for those patients, liquid nitrogen is an option, but it's not one that we commonly use.
Okay, great. Thank you. So I think we talked a little bit about second opinions, but perhaps we could continue this conversation between what maybe doctors are recommending and versus what a patient wants, what a patient's preference is. And so in this instance, the attendee says that the doctor is saying that the only option is Mohs surgery. And this person is immunosuppressed with other health issues, other comorbidities, and would really like radiation. So how do you balance those decisions? And as Samantha mentioned, getting a second opinion. So I'm interested in your response.
So I agree with Samantha. I encourage second opinions, even for my own patients, if that's something that they would like to seek. It's always great to get another perspective. We all, trained differently and, have different expertise. But for patients who are immunosuppressed, depending on the type of immunosuppression, they are at higher risk for having non-melanoma skin cancers that are more aggressive and behave, more aggressive biologically. And so you want to make sure that you get all the tumor out because it has a higher chance of coming back. And so I'm assuming that your doctor is recommending Mohs surgery because, as I talked about, Mohs surgery enables you to look at all of the margins to make sure you got all of the tumor, but it takes a minimal amount of skin away because it does it by layer. Whereas radiation could also be an option, and that's where I would recommend you to seek the opinion of someone else if radiation is something you really want to pursue. The problem with radiation is that, you can't actually see all the margins of the tumor because it is not a surgical procedure. And so the risk of the cancer coming back is probably much higher, especially for a cancer that already is more aggressive because of immunosuppression.
And so why is vitamin B3 not recommended for persons who are immunosuppressed?
Yeah, that's a very insightful question. Someone really paid attention to my wording. So I wouldn't say that it's not recommended for patients who are immunosuppressed. It's just that in the trial that was published in the big medical journal, they only enrolled patients who are immunocompetent, so not immunosuppressed. But there have been small studies where they have given this to patients with, different types of immunosuppression. It's just that we have to take that data with a grain of salt because it wasn't a big trial. But I don't think it's something that would harm you. You can talk about it with your doctor, and it's something that you could definitely try. Being immunosuppressed is not an absolute contraindication to trying nicotinamide.
Okay, thank you. If basal cell cancer becomes metastatic, where is it most likely to metastasize?
So basal cell skin cancer, like I mentioned, it very rarely metastasizes. I think the metastasis rate is like 0.003%. And what we are mostly concerned about that with basal cell carcinoma, when it gets aggressive and advanced, is that it is locally infiltrating. So it likes to invade in the skin, the bone, the nerves, the lymph nodes in the area where it is. But if it does tend to metastasize, we tend to focus first on, the areas that are near it, such as the draining lymph nodes, and then we'll go from there.
Okay, great. Thank you. So are there any topical medications available to treat basal cell skin cancer?
Yeah, so there are two currently used topical agents, and they're typically only used for low risk, superficial, thin basal cell carcinomas, and they're typically not considered first line because the risk of the cancer coming back is a little bit higher. But they can be considered in certain patients, and sometimes they can be hard to tolerate. So one drug or one topical that is used is called Cemiplimab, and the trade name is Aldera, for those of you that may know. And you have to, put it on every night for about 6 weeks, and it causes a blistering skin reaction and can be hard to tolerate. The other one is called fluorouracil, topical fluorouracil, and it also causes a blistering skin reaction as well. And so these are options that you can discuss with your dermatologist to see if they are appropriate for you and your type of basal cell carcinoma, because they aren't for certain types of basal cell carcinoma that are either nodular or, extend more down into the skin.
Okay, thank you. There was a request to repeat the dosing for niacinamide, the vitamin B3.
So the dosing for the nicotinamide is 500 milligrams twice a day.
And are there any other supplements you can take to reduce the chances of developing a basal cell carcinoma?
There aren't any other supplements that have been rigorously studied, but for some patients that, keep getting these skin cancers over and over and over, there are other treatment options that you can discuss with your dermatologist that have a lot more side effects than just this vitamin. And they're typically only considered for patients where these skin cancers are very recurrent because the side effects can be pretty hard to tolerate. So some of these are oral retinoid agents, so derivatives of vitamin A that come in a pill form, but they can be hard to tolerate. Sometimes there are certain chemotherapy pills that we use for, things like colon cancer and breast cancer that can also be taken that help decrease the rate of these non-melanoma skin cancers from forming. But again, these have much more severe side effects. And so it's always a discussion with your doctor.
Thank you. What proportion of those with a basal cell skin cancer develop another within 5 years?
So I would say in general, anytime you have had one skin cancer, you are at an increased risk of getting a second skin cancer. And that is why it's really important that after you've had one skin cancer that you follow regularly with a dermatologist and do skin checks at home. But in general, I would say, your risk of developing about 60% of the patients who actually have one skin cancer diagnosed, they'll develop a second one in about 5 to 10 years.
Okay. And so how do you know that you have a quote unquote good dermatologist?
So,
Right? I mean, how do you compare, second and third opinions? I mean, how do you make that choice as a patient?
yeah, no, I think that's a great question. And so what I think is really important for us, particularly as medical doctors, is you can always see if your dermatologist is a board certified dermatologist. There are medical boards that we have to take that ensure that we have the appropriate knowledge based on our training. And so we can deliver, competent, appropriate care for our patients. And so I would just make sure that if you see a Mohs surgeon, that there's now a Mohs board, which is new. Make sure they're, board certified by the Mohs board. If you see a dermatologist, make sure they're board certified. But more important than that also is just, after you visit with your dermatologist, you need to feel comfortable with that physician. And so even if that physician is board certified, but you don't have that report or you don't feel comfortable, then I think it's always fine to see somebody else. But I think it's mainly the fit is very important as well. So
Can I jump in for a second on that?
Absolutely.
Of course.
Absolutely.
So one of the things that we really encourage patients to do is to have a dermatologist who, one, will answer their questions and give them an answer. The first response may not be the perfect one, but if you've got a follow-up, is this person willing to talk to you and answer your questions? One of the things that you want in a dermatologist is somebody who's going to do a full body exam. So yes, many of the skin cancers that we've talked about are on the face and the arms and can be easily seen when you walk into the office. But is your dermatologist checking your entire body? Are they looking through your hair? Are you getting undressed and putting on one of those it's not a smock. I'm sure Dr. Park, you can jump in and explain what it is. But are they looking between your toes, under your feet, in all areas of your body? And so if you have a dermatologist who is not doing a full body exam, then it might be time to think about going to another dermatologist.
I think that's a great point that Samantha brought up. Yeah. The total body skin exam is really important. Head to toe.
Michelle, did you have anything you wanted to add about that?
Yeah, I basically echo both of those statements, that it's really important to have trust with your dermatologist and to also feel comfortable with them. Things can develop in areas that maybe, we're not so comfortable with somebody else looking at, but it is really important that those areas are viewed. You should be getting into a gown. You should be having your feet looked at, your scalp looked at, a really, really thorough exam. And then also if you have anything that you find on a self-exam, making sure to bring that up to the dermatologist and, get those concerns addressed. Because a lot of times patients find things themselves. We know our bodies best and we know what's been there for, 15 years and hasn't changed, or what's been there for 5 years and is changing and growing. And so making sure that anything that you have concerns about are examined properly.
Great, thank you. So I see this question about, do AKs ever become basal cell carcinoma?
And that's another great question. So AKs, which is short for actinic keratoses, they are typically, there's 50% of the people that believe that they become squamous cell carcinomas, so not basal cell. And then there's, maybe about half the people that think that they just stay AKs, and AKs are not really a precursor to squamous cell, but they typically don't turn into basal cell. They typically turn into squamous cell if they turn into anything at all.
Okay, thank you. I don't see any more questions at the moment, but perhaps our presenters would like to add some final comments. We can start with Michelle, if you have anything you'd like to add that maybe wasn't asked or you think people should know.
Sure. I think I will leave everyone with that prevention is key. Making sure that you are wearing sunblock, keeping any areas that are exposed to the sun, either applying sunblock frequently, keeping those areas covered, whether it's with a hat or sun protective clothing. There's a lot of different brands out there nowadays that have sort of a built-in SPF in their product, and staying out of the sun. And also making sure that you're following with your dermatologist. We know that with every type of skin cancer, the earlier it's caught, the earlier it is to treat. And I think just, keeping open lines of communication with your physician. If you are diagnosed, making sure you understand the treatment plan, making sure you're comfortable with the treatment plan, and if at any point you're not, certainly seeking a second opinion.
Thank you. Samantha.
So first, I want to thank everybody for joining us today. It's been an honor to be here this morning. And I want to say that you guys are your biggest advocate. You know what's most appropriate for you. You heard about treatment options that have side effects, and even things like surgery, although minor in compared to the immunotherapies. And so if you have concerns or questions, I encourage you to address those with your provider. Hopefully one would think that they are there to support you and to help you and to answer your questions. Knowledge is power, and if there's anything we can do to help, please let us know.
Thank you. And Dr. Park.
Yeah, I would like to echo both what Michelle and Samantha said. We're partners with you during this journey at any point, even if you have early stage cancer or late stage cancer. And so, we're there with you. And I think it's really important, prevention is key, because I sometimes, unfortunately see patients where the disease, has been, gone really far, and we can still help those patients. But, if we had caught it earlier when it's, most curable and easiest to treat, we could have prevented some of the things that, can happen. We do have great drugs nowadays, but if we can, not get there, that'd be even better. And so, but that's why we also have clinical trials, so we can really, help patients, for those patients that, the disease is really aggressive. And so I just want to also thank everyone for joining us today too, and also thank Michelle and Samantha for their wonderful insights alongside mine. But this has been a great webinar, and I hope everyone was able to learn something, and I think we all learned something as well.
Yes, thank you so much. Thank you for attending. And NCCN Foundation would like to thank the corporate supporters of this webinar. Thank you, and have a good rest of your day.